Tuesday webinar series, Chiropractic Economics Webinar for Doctors of Chiropractic. I'm Rick Bach, Editor-in-Chief of Chiropractic Economics Magazine. Today's webinar, Harnessing the Innate Power of CBD in Clinical Practice, Pain and Beyond, is sponsored by TrueGen3. And as always, our program is being recorded and will be archived at Chiropractic Economics website, www.chiroeco.com/webinar for 1 year. Our expert is on board here today to speak with you, and when his presentation is complete, we'll follow with a Q&A. You can submit questions throughout the presentation by clicking on the appropriate icon on the right side of your screen. Our presenter today is Dr. Chris Milius. He is an independent clinical educator for TrueGen3, and he is helping chiropractors and their patients understand CBD's fast-growing popularity in the pain management realm. Dr. Milius, thank you for taking the time to participate in our webinar and for sharing your expertise with CBD and helping our audience get a better understanding of what many are describing as a miracle drug. Before we get started, Dr. Milius, can you please give us a brief background on yourself and your work with TrueGen3?
Well, certainly. Well, thank you one and all for attending. I am a huge fan of chiropractic. In fact, I have 3 chiropractors that work on my body, and thank goodness for you folks, because you've saved the bacon for myself and my family. So first and foremost, thank you for what you do. I have been a naturopathic physician for 26 years here in Oregon. I serve as a primary care provider. I was a dean at the Naturopathic College for 7 years. I have written a couple hundred national articles. I've gone around the country lecturing for Category 1 AMA, CME, and I've written a whole series of articles on the endocannabinoid system, one of the items we'll talk about today, CBD, and the applications in clinical practice. So we're all the foots on the ground. We're all there trying to help our patients liberate themselves from their stuckness and their brokenness and regain homeostasis. So I've also provided a 16-hour lecture series that trains practitioners on the applications of CBD, everything from the brain, the gut, onwards and onwards. In fact, one of the interesting things before we get started, there's a new word called endocannabinoidome, big long word. And can't win Scrabble with that because, of course, it takes too many letters, but how even the endocannabinoid system is altering our microbiome, our friendly bacteria. So lots of fun conversation today. My goal today is to leave everybody, regardless of your knowledge base, coming into this conversation with pearls that you did not know or were not fully aware of. So I love being an independent educator because the word in Latin, docere, means doctor, and we are all teachers. So as we look at the human body and we look at the applications of CBD, we first and foremost, and we see that we have a lot of pain. In fact, as you can see on the second bullet here, chronic pain affects some 11 to 40% of the population, with subgroups being higher. And who says this? The Centers for Disease Control. So we see it, but we know it's not only affecting quality of life, it's affecting their ability to participate fully in the life that we have. And so anything that can help with pain is, of course, a remarkable blessing to our patients and, of course, to our family members and to ourselves. So we're going to talk about pain, but we're going to talk about other topics relative to the endocannabinoid system. We've all heard the crisis. We have an opioid issue. So why don't we move from the poppy, the source of opioids, to hemp? And that's going to be the nature of our conversation. But once again, so we don't step in the proverbial mud again, we want to make sure we do it in a methodical fashion. But unlike opioids, CBD is not addictive and doesn't have that same effect physiologically in the body. So that's the good thing. The question is, whenever something takes off in any of our fields, where is fact, where is fiction, where's the fad? So we're going to focus on the science behind how does this work in clinical practice, and when patients come in claiming that CBD is a panacea, where's the evidence to this? So we'll discuss that today. And of course, I love questions at the end of the conversation today. So I created this slide just for our presentation today as a foundation. And so when we look at the CB1 and CB2 receptors, it was actually Mechoulam and Devane out of Israel in '92 that discovered the CB1 receptor was having affinity towards anandamide. Anandamide and 2-AG are 2 endocannabinoids, which you make, I make, our cat and dog makes, and any other mammal we love makes. So these endocannabinoid systems are working within the body. So we're working within the confines of the human body as we were designed. So that's the first thing. So whenever we start fiddling around with that with CBD or whatnot, we have to realize we're working to maintain the homeostasis and not shifting it too much one way or the other. So we'll talk a little bit about dosing as we go along and realizing that these are innate processes that right now, if you have a patient with fibromyalgia, a patient with a disc issue, their CB1 and CB2 receptors are actually helping modulate their pain, but there is such a thing called endocannabinoid deficiency. Many of us are familiar with the term adrenal burnout or adrenal fatigue. The same things that get us worn out on our adrenal glands or stressed out psychologically can also impact our endocannabinoid system. So when we see that sick and tired patient, most likely their endocannabinoid system has also taken a licking, probably continues to keep on ticking, but we need to nudge the endocannabinoid system. And so just like, once again, a great adjustment, just the right amount to get the job done, but not too much. So this is what we're talking about. And you'll see on the right-hand side here, the words FA, fatty acid hydrolase. That's an enzyme. It breaks down anandamide. We'll talk more about that. There's 2-AG. It's broken down by MAGL. So once again, just like we have serotonin reuptake inhibitors and think of SSRIs, our body has these built-in systems, and this is called our endocannabinoid system. Hopefully this picture captures it nicely. So it was actually in '92 that Mechoulam and Devane in Israel, Israeli doctors, actually discovered anandamide. But prior to that, they were doing research on THC. And remembering that a hemp-derived product has less than 0.3% THC, I have a slide on that, and so it doesn't have that psychoactive effect. So anandamide was actually affecting the receptor, the CB1 receptor, much like THC, the psychoactive, but not creating a psychoactive effect. So remember, anandamide made in your body every day. And for some people more, some people less. The Sanskrit word for anandamide, ananda means bliss. Once again, sick and tired, worn out, stressed out, anxious, in pain. Often we have to wonder, are there anandamide pathways insufficient to meet the commensurate amount of stress and pain that got them to your office? And the answer is invariably, often, more than not, yes. And so once again, what we used to think about anandamide in '92 was it only affected CB1 receptors. Well, that's true, but now we know there's many other receptors being affected by our natural endocannabinoid system. And likewise, when we use hemp-derived CBD, we're also going to affect TRPV1, another pathway called 5-HT1A, and this is controlling anxiety, pain, and pain perception, and also the PPAR pathway. So lots of research coming out, and my last slide, you'll see that we have to stay humble because it is coming fast and furious with the advancement of scientific research and the boom and the green rush of CBD research. So we've all learned this back in basic sciences when we learned our physiology and biology. We have a homeostasis. But when we get ill, we get a fever, I've fallen and I can't get up phenomena, we actually start triggering more endocannabinoid release. So once again, a natural pathway that actually helps support the body in a fundamental way. But if it's not there to do it commensurately, then we end up with problems. Think about the patient that goes in for a cortisone injection. If they had enough hydrocortisone to deal with their aches and pains, they probably wouldn't need that injection. But the worn out executive, busy mom, or individual that's just taking a licking and keeps on ticking, but they're really not ticking very well, they get a cortisone injection. Well, why wouldn't we give an oral dose of endocannabinoids or a topical delivery to actually help sustain another pathway which we know exists in the body? It's all about nudging the body in the right direction to stay in the Goldilocks zone. So when we look at the CB1 and CB2 receptors, we look at the distribution. We used to think, and once again, how science has changed, CB1 was just neurological, just a spinal cord and brain. Now we know that's not the case. We used to think the CB2 was only immunological and peripheral. We also know that's not the case. And you'll see, of course, the little chevrons throughout the body here. So CB1 and CB2 receptors are key players in the endocannabinoid system. We all have them, and we all have the endocannabinoid system. So when we use a CBD from hemp, for example, we're going to nudge those pathways. And I have a philosophy: start low, go slow. Because once again, if we can get a vertebrae or subluxation addressed with minimal impact or force, wonderful. It's all about getting the job done with the respect to the body. CB1 and CB2 receptors are located on the surface of many cell types. And once again, CB1 are more abundant in the central nervous system, that's a fact, but they're throughout the body. And CB2 receptors are found outside the body. In fact, a little interesting tidbit, CB2 receptors actually affect the mu opioid receptor and the microbiome in the GI tract. It's like, okay, so it has affected opioid receptor activity, but it's a CB2, it's a cannabinoid. But once again, our bodies, as we all know philosophically, work in concert. Holistic medicine, what a concept. And this picture, once again, created uniquely for our presentation today. And if you want to read some of my articles for free, go to drmelitas.com. I have several articles that I've had published in the Townsend letter on the endocannabinoid system. But as you can see here, anandamide perfectly fits within the CB1 receptor. That's what Mechoulam in '92, along with Devane, discovered. But that little rectangle square actually fits here partially. So it has a CB2 activity, whereas 2AG, and one of the other endocannabinoid, all fits perfectly within the CB2 receptor. But there's crossover. So once again, there's duplicity in the body. There's redundant systems to say, okay, we're going to get this job done. We're going to maintain homeostasis and fight entropy. So as you can see, anandamide is broken down by Fa. We had that on an earlier slide. That's an enzyme. So it's going to break it down. So once again, just like we have serotonin in a synapse or another substance in a synapse, we're also going to break it down. Likewise, 2AG is broken down by MAGL. These two enzymes, you say, well, why are you emphasizing these so much? Because it's going to be relate to our conversation today about Tylenol and NSAIDs and how they alter the endocannabinoid system as well. So MAGL and Fa will come into our conversation later on. That's why I'm going over the biochemistry here. So we know that CBD interaction with the endocannabinoid system is dynamic. And they're referring to a term called the endocannabinoid tone. And CBD inhibits the Fa enzyme. Remember we were just talking about the Fa enzyme. What does it do? It breaks down anandamide. So it inhibits it. So if you don't break down the endocannabinoid like anandamide so much, so Fa breaks down anandamide. CBD inhibits Fa. All of a sudden you have more natural endocannabinoid in your body. A penny saved is a penny earned, as you can see down here. If I can save my naturally created anandamide by using CBD, and clearly the body homeostasis-wise knows how to use anandamide, we're going to sustain the tone, aka endocannabinoid tone. So one of our therapeutic concepts here is by using a CBD, we're actually conserving anandamide and we're conserving the tone. CBD can also increase anandamide levels by preventing Fa from breaking it down. And inhibiting the Fa enzyme has been shown to be a useful strategy for treating anxiety disorders. So when our patients come in hurting, we know that an inflamed brain, and once again, CBD and anandamide are used for inflammation as well. Research is clear, and I've given many lectures on the topic, an inflamed brain is more anxious and more depressed and more foggy. So that brain fog people complain about, or perseverating on this thing, overthinking something. Once again, CBD has a phenomenal role there. It's also used for post-traumatic brain as well as PTSD as well, and other lectures that I give. Fa and MAGL are the key enzymes for the endocannabinoid system. We just talked about it. I'm repeating it, and just like we do with our patients. And the reason is we all come to our conversation today with different levels of knowledge. So once again, just recapping this, because this is going to be a pearl that we talk about quite a bit further down about conservation and how medications we thought used to work a certain way, like NSAIDs, have a whole nother mechanism. And we're even going to talk about capsaicin ever so briefly, and how, remember how we thought it depleted substance P? Well, it probably does that too, but it does something else kind of cool. So interesting, lots of research out here from South Carolina. Tweaking the endocannabinoid system might be a good way to treating inflammatory disease. Well, if we use that term inflammatory disease, well, now we're thinking, well, maybe what about colitis and sinusitis and rheumatoid arthritis and all these other itises, maybe something else that's not so specific. And one of our slides will even talk about endometriosis and pain in the endocannabinoid system. So most of our research, and I quote here, once again, this professor from South Carolina, of our research demonstrates that endocannabinoids are produced upon activation of immune cells and may help regulate the immune response by activating and acting as an anti-inflammatory agent. Thus, interventions that manipulate the metabolism or production of endocannabinoids may serve a novel treatment modality against a wide range of inflammatory problems. That doesn't mean we don't use boswellia or curcumin or something else in addition to help control the cytokines, but we want to support our first volley, our first defense, our endocannabinoid system. But remembering, if our endocannabinoid system is worn down, it doesn't have good tone, it means other aspects of the body, which also count on the endocannabinoid system, are also going to be waxing and waning. And we'll chat about that as well. So once again, Goldilocks zone, whether it be infection or inflammation, and we release more endocannabinoids if we have that ability. But now if we don't have that ability and we have breakthrough pain, breakthrough inflammation, that of course brings our patients to us, then we're saying, well, let me go ahead and conserve it, prevent the endocannabinoids from breaking down as much with some CBD. Remember how it conserves by altering those enzymes that otherwise break down the endocannabinoids? So that mechanism is very, very important. So you're more familiar with this than even I in clinical practice when it comes to the brain and thalamic nociception levels, but the CB1 receptors are also expressed in cells of the midbrain periaqual gray matter and in the substantia gelatinosa of the spinal cord that's actually receiving primary afferent neuron activity. It's like, okay, but there's a CB1 receptor. Anandamide actually, remember Mechoulam in 92, he discovered anandamide interacted with the CB1 receptor, our endocannabinoid system, which is worn down like every other aspect of the modern human being, and especially westernized world, where we just don't have a lot of adrenal reserve, a lot of mental reserve, a lot of immune reserve, because we live in a helter-skelter world. So in the medulla oblongata and the spinal cord, structures involved in the process of pain signals, more intense concentrations of CB1 receptors are detected in the superficial dorsal horn and the dorsal lateral funiculus of the spinal cord. Isn't that cool? And once again, remember, until 92, we didn't even know we had an anandamide in the human body. Like, oh, wow, our body makes. And if you graduate before 92, wasn't even a concept. And even after 92, it wasn't a concept. It wasn't made into our clinical research. Now it is. And this is why a lot of people are excited. And when we look at the synaptic side of things, once again, lots of research has gone into this. And you can see this beautiful picture capturing the fact that we need to have a calcium influx postsynaptically in order to have a release of the cannabinoid receptor situated in a specific small area for that synthesization, or for the endocannabinoids to be synthesized. Interesting, as you can see in red here, noxious stimuli increase endocannabinoid release. Once again, assuming you haven't already squeezed out your full endocannabinoid capacity and you're overwhelmed with chronic pain or allodynia, like a fibromyalgia, that chronic nagging centralized pain. And then once again, you can only do that for so long before, like a race or a marathon, you hit that wall and the pain is unquenchable. And it would go into management opposed to resolution of a patient. So anandamide's whole body wellness factor is quite impressive. It helps with pain, helps with appetite, helps with memory. Once again, we're not talking about THC here. We're talking about something naturally in our body. And we're using CBD to help conserve it and allow it to actually have a greater function within the body. It's also used for memory. Other lectures I give, and you once again go to drmelius.com, read some more articles on all these cool topics with oodles of references in all my articles. And so what's compelling here is we make our anandamide and our 2-AG from arachidonic acid. Most of us in our basic science training learned that arachidonic acid, that's pro-inflammatory. That's going to feed prostaglandin E2 pathways. That's not good, but now you'll totally eliminate your arachidonic acid to a large degree. Well, that's also your building block for your anandamide and your 2-AG. So that's not good. Once again, balance, not too much of any one thing. We see fad diets. We see all kinds of things in our clinical practice. And the more we practice and live in the clinical environment, the more we see. But what's interesting here, focusing on the crux here, Anandamide, yes, it affects CB1 and to a degree CB2. Anandamide also affects a whole nother receptor, TRPV1, which we'll chat about. And it also affects direct brain components like the 5-HT1A. But if you look here, anandamide can be metabolized through the LOX and COX pathways. Remember lipooxygenase, cyclooxygenase? There's drug categories here. And if you remember boswellia, often called 5-loxin as a branded item, kind of interesting. So we're seeing all these mechanisms that our body didn't realize even existed. And now we're seeing the mechanism, and always keeping it simple is my philosophy as a researcher, as an educator. I always like to see what's going on within the body. And always remember, structure begets function and function begets structure. And so as we look at the anti-nociception, by inhibiting the release of pro-inflammatory factors by non-neuronal cells located near nociceptive neuron terminals, CB2 activation helps. Well, CB2, remember 2AG, anandamide, impact this. So our endocannabinoid system, the CBD conserves these. So by doing CBD, we're having an effect on these receptors, but more importantly, we're having an indirect nurturing effect. And philosophically, you can think of it this way. Is it better to teach a person to fish or give them a fish? The sustainable model is to teach them how to fish. So that's our goal here, is you support with CBD, supporting the innate system as existed in the mammalian species for eons, and you're actually covering the basis of getting the body up to speed in a foundational way. So once again, structure begets function and function begets structure. Just a glimpse of the research. I actually put it in red down here, 2016 excerpt. And what you're seeing here is research showing what happens if you use a CB2 agonist, something that stimulates that receptor. And so they gave various treatments throughout, all kinds of drugs, other medications, because they now use a lot of synthetic agonists or stimulants to see what does it do. Decrease atherosclerotic plaques, macrophage infiltration, leukocyte adhesion, tumor necrosis factor alpha, onwards and onwards. They're saying, if this, then that. And once again, lots of research. So if you really want to go into the weeds, this is a great article to read. And so once again, you can read the whole article for free on PubMed, or if you can't gain access to it, I'll be more than glad to share it with you through TrueGen 3. CB2 stimulation and endorphins. CB2 immunolabeling has been detected on beta endorphin containing keratinocytes and the stratum granulosum throughout the epidermis of rat hindpaws. And they've actually showed the mechanism going on here, beautiful graphic, but they're saying here, these CB2 receptors would activate, stimulate release of endogenous opioid beta endorphins. That's a takeaway. So CB2 receptors would activate, stimulate endogenous opioid beta endorphins. So you say, well, go get a runner's high. But doc, my back hurts. Remember, I have a disc issue. Or remember, I have that knee issue. Or I have fibromyalgia. I can't go exercise. I can't get that beta endorphin. Could CB2 be one of the mechanisms? The answer is yes. And remember, also CB2 and the microbiome also play a role in stimulating the mu opioid receptor activity as well. So kind of cool to know there's a workaround when it comes to helping our patients with beta endorphin. So when we're looking at the activation of anti-nociception by stimulating peripheral release of endogenous opioids, CB2 cannabinoid receptor selective agonists are promising candidates for pain treatment. And it's been shown to have help with neuropathic pain. And in one of my articles, I also talk about a substance called palmitoyl ethanolamide. Once again, palmitoyl ethanolamide, a substance abbreviated PEA, nothing to do with the vegetable, by the way. And it actually is also a fatty acid amide, and it has an endocannabinoid-like system you can also give for your neuropathic patients, along with the CBD if the CBD is not doing the full trick. So just an amazing time in the scientific literature. And as you can tell, I kind of geek out and go into the literature and say, wow, isn't our bodies magnificently made? And the answer is yes, they are. Researchers tested the hypothesis that CB2 receptor activation stimulates the release of the endogenous opioid beta endorphins. And they talked about the mechanism, and it allows for the local release of the beta endorphins where CB2 receptors are present, leading to anatomical specificity of opioid effect. Once again, you can get a hydrocortisone injection into your shoulder or your knee or your hip or whatnot, but it's go a little bit systemic, but it's localized. Isn't it kind of interesting that the body sequesters and allows for a localized effect of where it's needed? And that substance I mentioned briefly before, the palmitoethanolamide, which is written out on one of the latter slides in passing, I'll point it out to you, actually also goes to targeted tissues where it's quote unquote needed per the medical literature. So CBD, our topic for the day. Now we know a little bit more about how it works, but let's take a highlight of in a standard practice where we're dealing with musculoskeletal issues, how can it help? Well, let's take a look here. It's neuroprotective, it decreases reactive oxygen species, it is vasorelaxant, this is good, helps with blood supply and helps diminish some of that congestion and helps on the PPAR gamma pathway. Now you start thinking, well, I wonder if that can help with some blood sugar, some other things. Your thinking is correct. Antispasmodic type muscles aren't our friends. Of course, they're guarding, of course, but their excessive spasmodicity is not. Anti-ischemic, we need blood supply for healing. And that's that one I was kept on saying, 5-HT1A. This is also controlling and helping with the neurotransmitters and having a happier perspective of outcomes from your aches and pains. Because sometimes no matter the happiest Tigger in the world, it feels like an Eeyore after they've suffered enough pain. The TRPV1, which we'll chat about more, another effect of CBD. And bone stimulant, might that help with a fracture or maybe even with an osteoporotic patient? Not making a claim here, just doing a little head scratching as we're chatting as colleagues. And anti-inflammatory, go figure that. All from CBD, and why am I excited about it? You can see why. And the topic and the title for this article is Non-Psychotropic Plant Cannabinoids, New Therapeutic Opportunities from an Ancient Herb. It was a 2009 pharmacological journal that actually was commenting upon this. So then we get to the cannabinoids and the prostaglandin inhibitors. So when we do that, we actually look at the fact that the enhancement, and you can focus on the red if you wish, the enhancement of CB1 receptor activity by some NSAIDs, indomethacin, some others, has been confirmed. So are you saying that a non-steroidal anti-inflammatory drug affects your CB1 receptors? We were all taught a whole different mechanism. And that mechanism still is true. But once again, to think that we only work in the microcosm of linear human mechanism, of course, not the case. And so to think that if a person is taking a non-steroidal anti-inflammatory, or you have to wonder if they're taking an herbal anti-inflammatory, might we have an effect on CB1 receptor? I would argue the answer is yes. And of course, we know one of the challenges of taking the prescription or OTC NSAIDs is gastrointestinal problems and increased risk of dying of a heart attack. We know that if taking a single dose of ibuprofen, way onto this column, actually increases your risk of having a heart attack. Could be the first dose, could be the 100th dose. We know there's a cardiovascular warning now about how NSAIDs can cause problems. So is there a time and place for NSAIDs? That's a personal and philosophical conversation. But if we can avoid them or minimize them, we're going to decrease the deleterious GI problems in addition to overt ulcers and bleeding out, but also leaky gut, as well as, of course, cardiovascular sequelae. Plus, if many of you are familiar, NSAIDs have been shown in some of the literature actually to cause more damage to the chondrocytes and joints and decrease the healing within the joint. So it's purely palliative. It's important to control the inflammation. We would all agree with that. But the question is, if it's also taken away from the health savings account of that joint, is it really the best long-term solution? Of course, we would argue no. So NSAIDs and the endocannabinoid systems have the capacity, once again, NSAIDs to inhibit Fa. Remember how I emphasized Fa? That's the one that breaks down anandamide. An alternative hypothesis suggests that COX-2 enzyme can metabolize the endocannabinoids like anandamide and 2-AG, and that epidural administration of NSAIDs prevent anandamide destruction by inhibiting the action of COX-2. Okay, that's another mechanism. But once again, it's coming back to what? Our endocannabinoid system, which of course CBD can help conserve and support. The administration of NSAIDs increase the amount of anandamide by impeding the metabolism through inhibition of the COX-2 and or Fa, as we chatted about. And the only COX-2 inhibitor that I'm aware of is Celebrex currently on the market. So our patients get in an accident, they get a neck injury, they got inflammatory processes going on, and what happens? Well, the COX-2 exerts a negative influence on the endocannabinoids because it catabolizes them. Remember, anabolism, like anabolic steroids, builds things. Catabolism breaks things down, like too much prednisone, too much stress. And so as anandamide and 2-AG have been shown to have neuroprotective properties in injured brains. So this is why CBD is becoming very popular in the football and sports arena as well, or the hockey players, or the high school sports person, or the person playing a gentle game of lacrosse and takes a hit to the head. It's just all these considerations of how, once again, CBD can be used prophylactically, therapeutically, and it's actually helping rebuild and recuperate some of the endocannabinoid tone that we've chatted about. In a traumatic brain injury model, COX-2 inhibitors treatments protected 2-AG levels, enhance functional recovery, and reduce cell death and inflammation, confirming an interaction between endocannabinoids 2-AG and COX-2 enzyme. This also suggests that COX-2 inhibitors treatments may produce an indirect enhancement of the cannabinoid receptor activity by increasing endocannabinoid levels. But we're saying, but Dr. Melise, we were just talking about COX-2 maybe isn't the best thing for people to take, a drug, right? But what else can increase endocannabinoid system? Well, CBD seems to increase endocannabinoids. So we can do the drug therapy if necessary, or if it's commensurate level of injury, short term, but while at the same time, in my clinical opinion, using a CBD as well. And when you look at the neuropathic side of pain, because of course nerve pain sucks, and we all know that we have patients with that burning neuropathy or the tingling or paresthesias or whatnot. And they looked at 5 recent preclinical studies that published from 2013 to 16, and this was actually in the Annals of Palliative Medicine 2017 reported. And they looked at the studies, and they looked at chemo drugs, which cause allodynia, that centralized kind of pain that fibromyalgia and chemo patients will have. And they looked at it in terms of, can it help? And the answer was yes, it does seem to have great promise and allodynia, that systemic pain. So I'm thinking, well, what about the fibromyalgia patients with allodynia? The answer is, makes good sense. Once again, looking at always the cause. Am I claiming this is a panacea? No. But does it make sense to support the endocannabinoid system in a way? And why are our patients so excited to hear this soft science? But here's the hard science. Then there is a mechanism here. And as clinicians, if we employ that mechanism, wow, especially with a start low, go slow concept, we can actually do it in a very safe, methodical fashion. So that same study, 2017, these studies also provide insight into the biological mechanism behind the therapeutic utility of cannabis compounds in managing chemotherapy-induced neuropathic pain, and provide a basis for conduct of future clinical studies in patients of populations. I use the cannabis word. What does that mean? Well, there's 2 plants that are known as cannabis. There's the cannabis hemp, which is low naturally in THC, and then there's cannabis marijuana, which is high in THC, which we think recreational high THC. Hemp-derived CBD with little or no THC doesn't have any psychoactive effect. We'll go over that when we go over a certificate of analysis showing we don't have the psychoactive component. But when we hear the word cannabis, it can be used interchangeably. We don't like to use it in the hemp industry because it's confusing. But hemp is cannabis, so is marijuana. But we're not talking about marijuana in the clinical applications here, even though, of course, you could use it that way. But then you have that psychoactive effect, and most of our patients couldn't maintain their job or function with a large amount of THC. So beyond CB1 and CB2 receptors, we have additional proteins. You heard me talk about the 5-HT1A, the TRPV, the CB1, CB2. We also have coupling proteins. So is there science here? Yes, there's a lot of science saying, hey, look at here. So this is actually in a 2017 PubMed article, talk about G-coupling proteins and how they also have an effect via the phytocannabinoids like hemp and CBD. And so they looked at the GPR18 and GPR55 receptors, and they looked at the extensive sequence of homologies of CB1 and CB2, and they're saying there's a whole nother mechanism here, a different set of ligands rather than just the endocannabinoids CB1 and CB2. So when we give CBD, We're affecting coupling proteins. We're affecting CB1 and CB2. We're affecting anandamide and 2-AG. We're affecting the TRPV1 and the 5-HT1A. But we're nudging it at a gentle level, and we're increasing that endocannabinoid tone. A patient will start on maybe it's like 20 milligrams once or twice a day. And you'll see, okay, how is that working as it replenishes, or I call it re-soaks the sponge. So imagine a dry sponge in you're in your office where you're using electrostim or something. It takes a while to really get it fully saturated for a good conduction. Well, it's the same thing here. It takes a while to saturate and get the body back up with endocannabinoid tone. So going slow and being methodical, very, very important here. So they talked about the GPR18 and GPR55 may also recognize the phytocannabinoid CBD. Aha! So once again, another mechanism. We're teaching a person how to fish. We're supporting the body with CBD and allowing it to go rippling through ever so gently the natural pathways, some of which we know and some of which are yet to be discovered. Remember, it wasn't until 92 we even knew we had an anandamide endocannabinoid substance. So as promised, I was going to talk about TRPV1. Well, TRPV1 is compelling because many of us have used capsaicin topically for patients, right? Cayenne. And we often learn about substance P. Well, if you take capsaicin, apply it to, let's say, a shingles or a neuropathy, it will deplete substance P. Okay, that's fine. But now we're saying, it also affects the TRPV1, much like CBD does. So different mechanism probably at some fundamental level. But now imagine doing some capsaicin for a neuropathy or nerve pain, some CBD. Might we have a beautiful overlap? And clinically, I see that all the time. Once again, figuring out the body. It's like a puzzle. We have to basically tease it away. And so this TRPV1 stands for type 1 valenoid receptor, and it may regulate some cannabinoid effect. Once again, remember, we didn't even know we had a receptor or even had anandamide until 92. Now I wonder what else we're going to find. But look at the depolarization and actual potential initiation. And once again, burning, stinging, itching sensations. You can see where this could be very nice. Oxford University Press is the source of this picture. So then we look at the two serpentine receptors classified among orphan receptors, because when they were discovered, they did not exist a specific ligand to bind them. They say, hey, there's these receptors over there. And well, are they cannabinoid receptors? These two receptors are still named GPR55 and 119. Another receptor for anandamide is a transfer receptor, which we talked about, the TRPV1, and the receptor for capsaicin. Overlap, and the beauty of this, as we practice longer and longer, I think we're just continue to be baffled by what's happening within the body. To recap, when it comes to another journal article that was in 2011, we see some NSAIDs have additional influence on the cannabinoid system, either by inhibiting fatty acid amide hydrolase, that's the FA, remember that's the one that breaks down anandamide, or by inhibiting the possible intracellular transport of the endocannabinoids. So once again, we do not know, and I'm going to say it humbly, we do not know all the mechanisms. We just know it's well tolerated. You start low, you go slow. You can apply topically, you do it orally. Sometimes you have to Oreo cookie it both directions. But once again, once you get to that saturation level where you've replumped and improved the endocannabinoid tone, it's going to have a myriad of effects throughout the body. Mental, the psychological side of things, the physical, the neurological, and it can even affect GI health. And though I don't want to go over on time, I will share an interesting tidbit. Many of you know of the disease called respiratory syncytial virus. It affects children, most likely, or most often. And if we had two children, and one child has a CBD receptor mutation, aka polymorphism, the other one does not have that polymorphism, they have found a direct correlation that if that person with that polymorphism for CBD receptors exists, and they got respiratory syncytial virus, they're more likely to be hospitalized for that respiratory syncytial virus as a kid than if you didn't have that polymorphism. So it's going so much further into immunological effect, and even the inflammatory side of things, and also there's CBD receptors that have now been linked, if you have a polymorphism, a genetic mutation, to whether or not you actually will have a higher propensity towards irritable bowel syndrome. Go figure. So once again, breaks down anandamide, breaks down 2-AG. Once again, important talking points as we talk to our patients that we're actually helping to conserve the body. There's a relationship between the gut pain and endocannabinoids, a rodent study where they use an inhibitor for FAW, and they looked at the mechanism, and they looked at, did it decrease gut pain? And their answer is yes, it did. And IBS subtypes and their symptoms show distinct alteration of endocannabinoids and endocannabinoid-like fatty acid activity and levels, and partially results from the reduction of FAW expression. Once again, always going back to those words we learned early on, that FAW, and just like we have MAGL. And so what's interesting is we can help with IBS. Any of us have a stomach flu? How do we feel mentally? Not good. Do we have body aches? Probably. Have some reactive arthritis? Conceivably. Feel like death warmed over? Yeah. So healthy gut, healthy body, gut-brain connection, all of these things. So by also using CBD for those people that need to improve their endocannabinoid tone, we're actually going to be able to see some improvement and a healthier gut, healthier us, healthier microbiome. After all, there's 100 trillion visitors in our GI tract. There's 50 to 100 trillion cells that make up the human body, as many of them as us. So it's all about balance. Once again, out of the medical literature, as you can see at the bottom. Then we get the homeostatic role of the endocannabinoids also extends to the control of the intestinal inflammation. So, well, why is that important? Once again, if your GI tract, which has 80% of the immune system and 70 to 80% of your serotonin, a happy brain chemical, is unhappy, you're going to not have as good an outcome as a person that has a messed up GI tract as an unhealthy or a healthy GI tract, if there's such a thing as a healthy GI tract in today's world. So CB1 is a sensory ganglion, controls visceral sensations and transcription of the CNR1, and is modified through epigenetic processes under conditions of chronic stress. That can be physical stress, that could be psychological stress. It might have been before they even showed up to your office, they got worn out, they're complaining about their elbow or their shoulder or their first or second rib or whatever it might be, or intercostal problems. And they're like, but it's what got them to your office, which is always important, that whole history, finding out what's led the patient to the brokenness and symptoms that they have. And so the endocannabinoid systems will also involved centrally in the manifestation of stress. Aha! So now if we have a worn out endocannabinoid system, might we have greater manifestation of stress, physically or psychologically? Yes. The endocannabinoid signaling reduces the activity of the hypothalamic pituitary adrenal pathways via actions in specific brain regions, notably the prefrontal cortex, that's rational thought, amygdala, and hypothalamus. So how many of our patients can benefit from some Drenamine or some adrenal support? Well, quite a few. Well, if we do some support of the endocannabinoid system, might we help with some of those innate stimulants? Remember, we're teaching the body to fish, to take care of itself. I love this quote, so it's just phenomenal out of the peer review literature. Not going to spend a lot of time on this, just want you to take a view here of CB1 receptors and how it affects lower esophageal relaxation. So once again, think GERD, think of digestive problems, think of suppression of motility, secretions, and also over here, help with inflammation, visceral pain, think of that colicky pain that adults get as well. So it's like, okay, so it's having all these effects, and you're seeing CB2 and CB1. Remember, we thought CB1 was only in the nervous system. It's elsewhere as well. Likewise, we're seeing the same thing here with motility and regulation of the intestinal lining permeability. So if you're working with a gut patient, and it's kind of interesting because once again, it's not just about the spinal, it's also about all the innervations that occur from that spine. And once again, that feedback loop. And I've written a whole article on the vagal nerve, which is also available on my website, also for free. So when we look at the degradation, this is what's happening to the best of the knowledge at this point in time in the peer review literature about the receptor activity. And really all you want to be focused on is the 2-AG and the AEA, which is the fancy word for anandamide, and that it has all these different interactions. But you'll see the MAGL breaking it down and the cellular function. And once again, it's going for MAPK and some of these other postsynaptic effects. But anandamide and 2-AG can also be metabolized by COX-2, which is shown in the postsynaptic neurons, but can also occur presynaptically. So it's getting broken down every which way. We start simulating a COX pathway because of injury in our body. we want to kind of build up, in my mind, as a clinician of 26 years, we want to be supporting that pathway, shoring it up. And when we go for the GI tract and we look at receptors, we can see that CB1 appears to be the receptor that is most active under physiological conditions. Anatomide is a natural ligand of the TRPV1. And once again, endocannabinoids, ECS, endocannabinoid system, helps with secretions, motility, inflammation, and visceral hypersensitivity. So once again, lots of compelling information here. Healthy gut, healthy brain, better neurological functioning, all things being equal. And a tease on a much larger lecture that I give, oral administration of probiotic strains of lactobacillus that reduce visceral sensitivity were found to upregulate CB2 and mu-opioid receptors in the intestinal epithelium of rats. Blocking CB2 attenuates the reduction of visceral sensory thresholds caused by alteration of gut microbiome. So I got a little yogurt there, but you can figure a friendly probiotic of your choosing could actually help support this. So now we're looking at the endocannabinoidome, and once again, the microbiome, endocannabinoid system, and how the CB2 interacts with the probiotics naturally within the GI tract, or they've taken an antibiotic before they came to your office, they've been on multiple antibiotics for multiple infections, because they're one of those travelers that we have in our practice, and they constantly are ill because they're worn down, the adrenals are worn out. Well, we've learned about CB2 and the hypothalamic pituitary pathway. We've learned about the gut health. It's like, wow, we're really teasing it away here with CBD and the relationship here. And as you can see, chronic stress alters these pathways. It can increase short-term 2AG and AEA, but that's like asking your body to do a wind sprint. You can only wind sprint so long before you are no longer sprinting. You're barely walking one foot in front of another. So chronic stress, you get that endocannabinoid fatigue or deficiency that occurs. And so lots of times our patients are coming to us with some of those symptomologies. And once again, always looking at the innervation pathways, afferent, efferent. And that's one reason I wrote about the vagal nerve so much, because 80% is afferent and only 20% is efferent. And there's a whole condition called Rome-Held syndrome, which also CBD seems to be helpful for in my clinical practice. And when we look at chronic stress and pain, the ECS is involved in the response to pain. Stress evokes changes in the levels of anatomide 2AG. So once again, that's assuming they have that reserve. If not, this is where CBD comes into play. And you'll know whether a person is doing really well with the CBD because they're going to start having some symptom relief within a few days usually, and definitely within the month. That's what I see, assuming you dose judiciously. And once again, it's also about getting it delivered to the tissues bioavailability wise. And we'll chat about that briefly as well. So I think I'm on time, so do not worry. Lots of times for questions. And chronic stress causes downregulation or loss of CB1. That's a take home as well. Chronic stress. Hey, any of us as practitioners chronically stressed? Oh, wait, we went from ICD-9 to ICD-10 coding. We just got an audit from another insurance company. They want more chart notes to justify what we already know we're doing well. And it's like, oh, no chronic stress for us either. And we cause a loss of CB1. And these changes are widespread and occur throughout the brain. So once again, this whole aging process, we look at our hormones. And remember we talked about hypothalamic pituitary and that feedback loop gets messed up. Is this part of the excessive aging process that might affect growth hormone, testosterone, estrogen? Hasn't shown up in the literature yet, but I've written a whole book on his change of life and how testosterone levels are very, very broad in terms of what's causing the problem. It's not just one thing causing low hormones or worn out adrenals. And so they talk about increased 2AG signaling correlates with the termination and adaptation of activity of the hypothalamic pituitary axis, so the brain, adrenals, and contributes to changes in pain perception. How many patients come in with adrenal burnout? A lot. Or adrenal fatigue, lower cortisol levels, and cortisol-cortisone interchange in terms of conversion. So once again, if you don't have enough hydrocortisone, you're going to have more breakthrough pain, more inflammation. But now we're seeing there's this whole nother mechanism with the endocannabinoids, and once again, how does CBD come to play? And beautiful picture here, in my opinion, in terms of stress. It's altering our hypothalamic pituitary axis. It's altering the corticosteroids, cortisol, cortisone. And as a result, were getting sick patients. And all this time until 92, we didn't even know it existed. And until possibly this conversation, you didn't even know that along with that adrenal fatigue, we had not been addressing the endocannabinoid system for those chronic pain patients with the breakthrough inflammation. And we just doesn't seem to do the trick. Because I can tell you, all the turmeric in the world, all the boswellia in the world can't make up for a dysfunctional endogenous system, which is unhappy. Just like all the herbs in the world can't make the adrenal glands work better unless there's an innate healing capacity that is present and is being nurtured. So when we look at the complexity of it, and I just do this as a brain wow, look at where the receptors are that we currently know. Once again, beautiful graphic out of this medical journal. It's like, okay, I'm humbled. And the more I research this stuff, the more humbled I am. So anxiety, appetite, nausea, pain. Well, we have patients all the time with all of those. Depression, yes. Affected the prefrontal cortex, the amygdala, the hypothalamus, and the hippocampus, yes. And so once again, this is where CBD comes to play. You nurture a pathway, you see what that body's resilience is, the vital force, if you want to call it that, and then you'll see how much more does it take to get the job done. Starting low, going slow. Acetaminophen, Tylenol, once again, they looked at endocannabinoid reuptake inhibitors and CB1 receptors, and it may be responsible for the analgesia induced by acetaminophen. Okay, I thought there was a very vague other understanding of that. Well, this is the 2018 article, last January, talk about, well, actually maybe acetaminophen's working on another mechanism, and maybe a CB1 receptor, which really makes us wonder as clinicians, where does CBD come into play in modulating everything? And when we look at acetaminophen being used or NSAIDs being used, if they can impact the endocannabinoids, are they disruptors? And are they positive or negative disruptors? And I will tell you on another lecture I give, I talk about how acetaminophen is also a poison to the mitochondria. And of course, that's a whole nother conversation in a book I just wrote on the mitochondria. But acetaminophen has been shown to cause a problem with mitochondria. And it's also strongly discouraged for my patients which are pregnant, avoid acetaminophen, even though they say it's okay, because it actually could cause mitochondrial issues. And there's a link to susceptibility to non-neurotypical problems such as autism. So acetaminophen relieves inflammatory pain through CB1 cannabinoid receptors and a rostral ventral medial medulla. And I quote here, our results indicate that the cannabinoid system contributes not only to acetaminophen analgesia against acute pain, but also acute inflammatory pain, and suggests that the relevant CB1 receptors reside in the rostral ventral medial medulla. I know I was not taught that at all in basic sciences, clinical training whatsoever. Wow, a 2008 standard medical journal saying, so why is CBD exciting for us as clinicians? Yes, our patients know about it. They're bringing it to us, but now we know more about the mechanism and that it's real. It's very, very real. And our bodies have been using the endocannabinoid system for eons, and now we're seeing the mechanism here, whether it be the NSAIDs, mu-opioid receptors, presynaptic GABA release, the output of the neurons. But once again, where does 2-AG and AEA, which is anandamide once again, come into play? Well, comes into play there. SAFA breaks down anandamide. They should have here an MAGL for the breakdown of 2-AG. But they're saying here, indicating that increasing levels of endogenous endocannabinoids protect against the damaging effects of the drug. And which drug is this? The NSAIDs. Because what do the NSAIDs do? They can cause ulcers. So I'm not saying that you do enough CBD, you're going to avoid ulcers when you give a patient an NSAID. But the fact is, like, wow, there's a natural protective mechanism here. And once again, European Journal of Pharmacology, 2017. So lots of research going in here. We already know that GW Pharmaceuticals made a drug out of CBD. And so once again, it's very interesting that it's coming to this play. And NSAIDs that are known to block COX-2 can interact with the cannabinoid system due to a potential important degradation, once again, of the anandamide 2-AG and the COX, which we've chatted about. So I'm repeating some of this on purpose because they're important takeaways that mechanisms of actions which we were taught in graduate school were once again things which were not fully delineated, and they're delineating them more and more and more. and what we thought was the case, and then we had an exam when we were taking our board exams, and like, okay, that was the answer. Yeah, but the real answer should have been endocannabinoids, COX-2. Yeah, so once again, what we know, we're stay humble about. So we want to bolster the endocannabinoid system without question. Beautiful graphic. Once again, all these slides are going to be available for you folks. And we're going to be able to look at these, review them again, and I'm hoping to offer more presentations like this at different levels, but I want to speak very broadly to the group as we all come with different knowledges and different foundational research before we get there. So a couple more slides, we're going to open up for questions. Well, what about endometriosis and endocannabinoids? In women with endometriosis, there are elevated circulating levels of anandamide and 2-AG with a decline in local CB1 expression, which implies a negative feedback loop. This may interfere with the capability of these mediators to manage pain. Once again, pain takes all kinds of forms. And once again, the authors say, these preliminary data suggest that the pharmacological manipulation of the action or levels of these mediators may offer alternative option for the management of endometriosis-associated pain. Reproductive sciences. So once again, they're looking all over to see, now that we found our best new friend, the endocannabinoid system. Remember Hans Selye back in the 30s talked about the fight or flight response and having discovered the stress response. Well, now this was the 92 discovered, 60 years later. I wonder what else they're going to discover. I hope I can hear the next big thing before I'm done practicing. Joint pain, once again, lots of research showing that it has tremendous ability with joint pain. Preclinical and human data that do exist indicate that the use of cannabis should be taken seriously as a potential treatment for joint pain, and once again, 2017. And when we look at modulation of pain, once again, it's affecting the GABAergic, which is GABA, remember, that's inhibitory, that's calming, it's relaxing the body's responsiveness. And they talk about the fact that the cannabinoid agonists retain their efficacy, whilst morphine does not in animal models of neuropathic pain. Remember how we start with moving from the poppy to the hemp, changing plants? Well, once again, we know that morphine, you get habituated, you need more and more opioids. Well, the cannabinoids, you don't end up needing that, especially when you start low, go slow, and work within that person's need. If a person's a little thirsty, you give them a little bit of water. If a person's really thirsty, you give them more water. Very commonsensical for us as clinicians. But patients in our country are supersize me, go for more. Not necessarily. And so as we finish the slides here, CB1 and CB2 receptors, very important, but there are other receptors as well, the TRPV1, the 5-HT1A, as well as G coupling proteins. And phytocannabinoids such as THC and CBD are also known to activate CB1 and CB2. But in our clinical practices, we are not wanting THC in the clinical practice. What we do recreational is a whole nother conversation between us and our boards. But the CBD, you want to make sure that we're just using CBD and we're not going into the marijuana side of things. This is why using a company which has either no THC or documented very clearly less than 0.3% THC. Well, that's where the Farm Bill and the hemp rule comes in. That's considered hemp, less than 0.3%. So what happens if you can increase the absorption of a substance, not only as you take it in orally, but it gets through the GI tract better, goes systemically better? Well, that would make good sense. And this is called a Vesisorb. It's a technology that's used by TrueGen to actually help with the dissolution of things which otherwise might be hard to actually get delivered. So once again, something's only as good therapeutically as the ability to absorb. You found this with topicals before. One that smells really good and really powerful, but really didn't help a patient. And you found your favorite topical in your clinical practice. Well, it's the same thing. Well, I tried CBD, it didn't work. I have patients all the time come in, or I tried magnesium, it didn't work. But did you take the right form and the right delivery mechanism? So the concept here of Vesisorb is that causes an association colloid. So if you were to pierce a capsule of a Vesisorb put in water, it's actually going to dissolution. It's going to dissolve much better than one that does not have this technology. So as a result, what are we? We're largely water. So it makes sense that we have that dissolution. And if you look at the C of A here, certificate of analysis, any CBD product I have in my clinical practice, I want a certificate of analysis. I want to see what are the actives, but I want to make sure there's no THC here. As you can see here, none detected. So there's no question, is there a psychoactive? There's no psychoactives documented. Plus, you're looking for what's called the hemptourage effect. So there's an entourage effect, which is usually limited to marijuana. Well, the hemptourage effect is cannabidiols, interaction with the beta-caryophyllene, the CBG, the D-limonene, and others. Once again, plants come with a whole array of other actives. Like vitamin C is great, but vitamin C with bioflavonoids is more natural and more effective on some days on absorption. So the concept here is we know a lot about CBD. We know it's what we're talking about today, but some of these other things like the beta-caryophyllene, the D-limonene, are all things which also have their own therapeutic effect. We do myrcene and other things. Plus, you want to make sure you're not giving a patient, and we all know this, things that are toxic and or contaminated. So once again, a C of A for all your supplements is very important, but particularly in CBD land. So once again, not detected, very important. You want to have it non-detected. So start low, go slow, work with a gentle modulatory pathway of the endocannabinoid system. We're working within something our body's been doing for eons, and eons of eons for generations. I usually start with 15 to 25 milligrams per day. You can start higher if you want, and then move to 2 to 3 times. Always put the foot in the water and see, kind of reminds me of the show Jaws, do, 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 do. I always start low. Hey, if a little bit does a trick over a few days, wonderful. We found the magic dose. If not, we go higher. Once again, BID twice a day, TID 3 times a day, as tolerated and as needed. If less gets the job done, wonderful. Mission complete. Some patients will need much higher doses, but once again, don't overshoot because we don't want to overshoot the minimal effective dose because we're nudging the pathways. Scientific literature has shown up to hundreds of milligrams per dose. In fact, one of the lectures I give on anxiety, the scientific literature shows 600 milligrams per dose for anxiety. Like, was that really needed? But once again, they funded the study. They want to have an effect. So they went for a very high, dramatic dose. I usually find these lower doses do the trick the vast majority of the time. We can always go higher. Nothing wrong with that. And we want to support other biochemical pathways. Of course, always diet, lifestyle, supplements. And remember that fancy word I told you about, palmitoyl ethanolamide? That is another fatty acid amide, which is endocannabinoid-like, which helps with neuropathic pain. So once again, whole nother pathway, but the literature is just so compelling. I always like to use other anti-inflammatory herbs, so I'm working on either the COX or the LOX pathways in lieu of, majority of the time, the NSAIDs. So as a result, we are, I think, done, but I think we just need to stay humble in realizing that we're continuously learning. There's recent review showing 65 potential molecules target for CBD, and 65 so far is what I would say. So I'm going to open up for questions.
Thank you, Dr. Miletus. This has been extremely informative. We've been collecting some questions from the audience that we're going to get to. We've got time for 3 questions, but any questions that haven't been answered, we'll add them to the final transcript, and afterwards we'll have a special offer for our webinar participants. Our first question, a doctor asks, do we need to worry about drug interactions when prescribing CBD?
That's a great question, and I can actually provide some information on this. GW Pharmaceuticals, the drug company, did some studies on this. When you go for high milligram doses, yeah, possibly. When you go for the lower dosing, have never seen a problem. There is something called a cytochrome 450 pathway. It seems like this doctor's dialed in on drug interactions. So if you do too much grapefruit, you'll affect the cytochrome 450 pathway. If you barbecue too much, you affect another pathway. So the answer is on the lower doses I were talking about, never seen a problem. If a person's super sensitive, tell them to talk to the pharmacist, but never seen a problem with the reasonable dosing regime.
All right, another question for you. Is vaping CBD more or less effective than a capsule?
The vaping side of things, of course, beyond the fact that you're absorbing through a lung. Lungs are a great way to absorb things, but I think using it in a more bioavailable oral dosing really works better and offers more deliverable, and it's also more economic. I've had patients do CBD vaping, and it just doesn't seem to actually have the same effect. Now, if it's working for the patient and it's from a regulatory perspective okay, then I would say use what works. but I'm usually an oral dose person myself, or topical.
Okay, and our third question, is CBD okay to recommend to a pregnant patient?
The ultimate question that nobody wants to touch. I would say that would I consider doing that? The answer is yes. Would I do it in an exciting fashion in today's litigatory world? No. With 1 in 38 children coming out with autism, if they're boys, 1 in 145 for girls, do I want any part of even being part of that equation? The answer is no. Now, philosophically, body has an endocannabinoid system. Could it be helpful? Probably it could be helpful. Do I want to have the liability for it? No, I do not.
All right, thank you, Dr. Miletus. We also have a special offer for our webinar participants, a free 1-week sample of True Ease hemp oil, a $32 value. You can sign up for the free sample on the registration page at www.chiroeco.com, TG3 True Ease, TRUEASE. That's chiroeco.com/TG3 True Ease, the registration page. In addition to the free sample, you also receive an offer for 3 free when you purchase 12, which is a 20% savings. So at this time, we'd like to thank our sponsor, TrueGen 3, and Dr. Chris Miletus for today's webinar. And thank you all for attending. Remember, this webinar, including our speaker's PowerPoint presentation, has been recorded. We will alert you when the webinar is available online. Thanks again for attending, and we look forward to seeing you next time. Have a great day.